Thank you, Alan. Next will be Dr. Pierre Wolkenstein and Dr. Laurent Lantieri out of Paris, talking about quality of life.
So thank you very much to be there, and thank you to the organizing committee to have chosen. No, it's the other one. You want to start, Laurent? Maybe. So we will change the. Okay.
We are a couple. We know each other for 30 years. So. We love each other, we hate each other. It's like an old couple. So I'm Laurent Lantieri, and I'm a plastic surgeon. And plastic surgery for me is the surgery for quality of life, basically. What I'm doing every day is to improve quality of life of patient. I don't do only neurofibromatosis. I do a lot of them, but I do breast reconstruction after breast cancer. I do also cosmetic surgery. I do burn sequelae. I do a lot of things. And each time people are asking me, but how do you define what you're doing? It's not making nice pictures. I don't care about the pictures. And maybe the only plastic surgeons that don't care, do not show pictures of patient in front of patient, try to sell something. What I care is about quality of life. For instance, if I do a breast reconstruction after breast cancer and a patient is climbing mountains, and she tells me I don't really want to take anything in the back because I want to climb mountains. I said, don't do any reconstruction. I prefer to have a patient that have a nice quality of life than just for the pictures. So I'm going to talk about surgery. Oh well, you know about neurofibromatosis. You know everything. The problem in surgery in neurofibromatosis type 1, I do type 1. I do von Recklinghausen. I don't take care of type 2 neurofibromatosis. It is difficult. Very few surgeons take care of it because it's bleeding a lot. It's difficult, so there's a high risk for the surgery. So if you want to improve quality of life on one side and you have a risk on the other side, the surgeons don't want to do it. The results are, they say it's poor, but it's poor on pictures. But the patients say they are improving. And because the skin is not normal, so we have to change, I had to change the way we are treating the patient compared to the conventional plastic surgery. It is difficult to reproduce because, as you know, there's no two patients are same. It's not like, let's say about breast reconstruction. Breast is removed, you put another one. A finger is cut, you put the finger back. Here it's so different that it's difficult to reproduce and to teach. And there is nothing in the literature. So when Pierre sent me patients in 1990, we started in 1994, 1995, and I started to do patients one after the other, trying to see what I could do, case by case. And in 2010, I looked back at all the series we had, and there was a very huge number of patients that I could operate. Large number of operation. It's the largest series of operated patients that could remove large tissues progressively. I look at the different data, and you know, in medicine we need to have publication and look at the localization, different things. So I try to make it very scientific, because people are saying me, when you want to publish, to make scientific. But you as patient, you don't want science, you want to be cared, to be cured. It's not the same thing. So my problem is, what is the surgeon's perspective? What is my perspective converted to one patient? What am I doing? Am I improving? And I wanted to diffuse what I was doing to the others. How does it fit to what we call today evidence-based medicine? What is evidence-based medicine? I have to teach you about so that you can understand why it's so difficult to have all those publications, why it's so difficult to get access to new treatment. Before the 20th century, teaching medicine was empirical. We knew something, we were teaching to somebody else. It was a few things. It was companionship. It was the goal was seeking to heal, not a cure. And as a French surgeon of Paré said, "Je le pense et Dieu le guérit." I bend him, and it's God that heals. That was before 20th century. And in 20th century, with science, we discovered therapeutic. We discovered drugs. Vaccine, asepsia with Pasteur, penicillin with Fleming. And at that time, a lot of drugs appeared. But all these drugs were efficient or not efficient. So we had to have evidence to see if a drug is efficient or not, or a treatment is efficient or not, compared to new treatments, because there were new treatments every day. So how do we do that? We do what we call level of evidence. The first level of evidence, the best evidence, is when you do what we call a double randomized study, blind study. You take the drug A, you take the drug B, you take patient, and it's randomized. The patient doesn't know the treatment he's taking, and we at doctor, we don't know which treatment we're giving. And after that, we analyze with statistics, and we know that statistically it is evident that this drug is superior to the other one. You realize that it's not possible in surgery. I cannot provide two treatments blindly. You cannot blind the surgeon to operate. So already we do not have in surgery level 1 evidence. And if we look at the different evidence, let's see about other things in life. If we ask a scientific question, can we walk on the moon? It is a scientific question, and it's only a few people that walk on the moon. 12, 13, 14, I don't know exactly. The small numbers is sufficient to say that we can walk on the moon. So when you say, the problem is that when we try to do all our large series, in your case, neurofibromatosis is a rare disease, and we say, well, we have only a few cases, the scientists are saying to us, well, it's not true because you don't have large numbers. We need you to show that it's not true. With small numbers, you can have evidence. And even worse, parachute. If I analyze parachute in the evidence-based medicine principle, there are people who have jumped from airplanes without parachute who didn't die, and people who jumped from airplane with parachute and died. Nobody has ever done a double randomized blind study to study the parachute. And if I say that, and I say, well, is it evidence? Then we say, in evidence-based medicine, you should not use parachute when you jump from airplane because it's not proven to be efficient. So that's a difficulty we are dealing with, what we're trying to do, and specifically as a surgeon when I treat one patient after another, trying to see what are the evidence. You can have large series for drugs, very good, level 1, and the drugs are bullshit and killing people, like Mediator, which was a big scandal in France. And the other things, like face transplant that you heard. I did personally 7 face transplants out of the 28 done in the world, and 2 of them were done in neurofibromatosis. You have to know that in a 28 face transplant done in the world, 3 of them were done on neurofibromatosis patients. 10% of the patients that received a face transplant in the world were patients that had NF1. But a small number. So they say it's not statistically significant. Can you click on the video? So this is Pascal in 2006. This is in Paris. This is spontaneous. You know the little girl showing around and say, oh, look at that man. It is spontaneous. It was not fake, not trouble. And Pascal, who had NF1, says, well, people are looking at me, it's awful. And this is 1 year after. After he had a face transplant. Well, you're uploading, but this is considered to be a low evidence because it's only one case. For you, for everybody, it's evidence. We are improving the quality of life of that patient. And even more, the patient now, can you click on the video? Pascal is able now to work. Can you click the video?
No.
Click la vidéo. Sí. Gracias.
No click.
It was working. Okay, anyhow. Oh, it's not. Anyhow, Pascal is able to work, and you can see here in this meeting, which was 1 year ago, Pascal and Jérôme, who are two patients who receive a face transplant for neurofibromatosis, they are doing well. Pascal is 7 years post-op of his face transplant, and Jérôme on the right, who had a full face transplant, is now 4 years post-op. Of course they have a treatment. Of course they have the problems of a transplantation. So what are we doing here? We are improving the quality of life of a patient. The difficulty here is that there are so many definitions of quality of life that it's difficult to analyze. And it's even worse when we try to have a scale, when we try to put numbers behind that. There are so many scales that each time we're trying to publish and say, well, you're going to use this scale or the other scale, say, well, no, you should use another scale and do back all your studies, so we cannot publish our results on quality of life, and it's very difficult. We are trying to have something which is standardized and specifically to use something that is used in other disease. Why? This is one of the scales which is used, which is very useful, the SF36. You have a number of questions, and you can see that you have the vitality, what you're doing, if you're tired, if you feel tired, if you have social problems, do you feel weak, do you have problems to walk, everything is combined, physical and psychologically, to see how is your life every day. And what we're trying there is to find what is the global burden of disease, how much does this weight, what is this disease, what is the problem. NF1 brings lower life expectancy because of MPNST, because of malignant tumors, and has a high impact of quality of life. There is no medical treatment today, but there's a need of treatment, and only surgery today can bring improvement for the patient. We are trying to use scales today, what we call disability adjusted life years, to see how many years a patient lives without disability, and to compare that with other disease, to make people understand that your disease, NF1, is something severe. If we only say, well, they have small tumors, skin tumors, well, and so what? But if we really have those scales of disability and life expectancy, we can really compare it to other disease. It is constructed. It's a thing that is going on, and try to compare the different diseases, specifically the one that have difficulty to analyze, which is the case of an NF1 because of the cosmetic aspect. We built it this way. The first way is to try normal and with disability compared to a number of standard population. And on the other side, we're comparing with the number of life. So we have a scale like that, which is the population, and this is what we are losing for a patient that has the disease, which is quality of life and number of years of life. We can calculate that. We can have numbers. By this way, we can compare to other diseases. And we can even go further, because if we're giving a treatment, whatever treatment is that, we can give what we call QALY, which is the number of years without any problem in quality of life we're giving to the patient by this treatment. Whether it's surgical treatment, whether it's medical treatment, it doesn't care. So for us, it's not important, for me, I would say, it's not important to see I'm putting 10% of a tumor off or 50% of a tumor off, I'm moving. What is important is, does the patient feel better or not? When I was looking at my series, looking at the pictures, I was not very happy, but the patients were very happy, more and more. They were satisfied. So what can we do? The first thing is for tumors, malignant tumors. We can treat them. We have a numbers, and by operating those tumors, we're gaining number of years of life. The other thing is, the problem is with these tumors is that it bleeds a lot. So the problem, no surgeons wants to treat that because it bleeds a lot. The problem of bleeding impacts the number of years, but at the same time we cannot treat this population, try to improve the quality of life because of the risk of bleeding. So the second step for me was to try to find a solution for surgery without bleeding in NF1. That was the point. And we achieved it by using different treatment. You see the number of bloods that we have when we are doing the surgery. And we did it and compare with new surgeons in my department, and we achieved that only 3% of the patients are transfused. In every literature, it's about 75%. So these techniques point way, we can go further. But each time I want to publish that, they say, yes, but really, you didn't do a double randomized study with a population with surgeon A, surgeon B. I say, it's not possible. I try to do the different techniques and I improve. It is a trial-error process, and progressively I improve until I found the solution, and then I applied it. That's the way it is, but it is. I'm going to go further and faster. So the other thing is pain. A lot of patients with NF1 have pain. And they have pain because they have tumors. And sometimes you remove one tumor and the pain is off. So it's a great improvement in terms of quality of life, even if you have other tumors. If you look at the data, have you removed the tumor? The answer would be only partially. So people are going to say, well, it's a partial result, so it's no result. But if you ask the question to the patient, no more pain, so it's a full success. So only looking at the pain problem, we are improving the patient. The problem when you are removing a tumor in a nerve is that the nerve injury can happen. Well, we can dissect the nerves and remove the tumors in most of the cases without doing too much injury to the nerve. And in our series, we only had one paralysis out of 35 cases. So when a surgeon says, I don't want to remove it because they are paralysis, I don't want to do it because they are bleeding, it's true, it can happen, but the risk is very low, so the risk benefit is to try to improve the patient. The most difficult for us as a plastic surgeon is to have a nice cosmetic result. What I understood by practicing is that the skin is not normal in patients that have neurofibromatosis. We did also studies on the skin trying to pull on it. The elasticity of the skin is not normal. When you pull on the normal skin, it pulls and it goes back like a rubber band. On a neurofibromatosis, when you pull on it, it doesn't go back. The collagen fibers and the elastin fiber disrupt, and it doesn't go back like a chewing gum. So we had to change all the practice we had in plastic surgery, and we had to do what we call major excision. We excise into the face, into the tumor. When we try to pull, it comes back and we have relapsed. When we remove directly, even the face, we have much better results. Our patients do not care about the scar. They are happy because there's less deformity. And here's an example. A patient with large deformity, removal, and with improvement, the patient is happy. Some results after we remove different tumors. And we can also, for patient who has paralysis, graft a muscle to have improvement. Of course, it's not perfect, but the patient can smile and doesn't have any more the paralysis. I'm going to go further fast because we can sometimes use the bone craniofacial technique to move the bone, to try to put it back in place, and to put the eyes back. And here you can see on that patient that had the eye which was really low, we cut the bone completely and put it back. It's not perfect, but at least when he's wearing glasses, we don't see the eye outside the face. Now we're trying to treat children. Why are we treating children? Because we are safe now in adults, and we're trying to go further in children. We know that we don't have the bleeding problem, and we know that during teenage, some of the tumors just explode, and we prefer to treat them before, like in this patient. For instance, Pascal, I show you the transplantation guy. When he was a kid, he had almost no deformity. It appears when he was a teenager. So that's why we're thinking to treat the most earlier possible. And transplantation. Transplantation is probably a solution for some of those patients, specifically because there's a drug that you maybe heard about, which is sirolimus. And this drug is a common drug used in the treatment of neurofibromatosis and the treatment, and is an immunosuppressive drug used in transplantation. But at the same time, we remove the malformation, we replace it with a healthy organ, and then we give a treatment that is at the same time a treatment to keep this new organ in place and to avoid the proliferation of the NF1 disease. But it is difficult and it is risky, so it has to improve a large quality of life. That's why you only see 2 face transplants compared to the numbers of patients that I've treated that are very much more important, 350 basically. So, of course, surgery is also important for our colleagues who are researchers, not only for us, because all these samples are sent to the units, they are analyzed, they make cell proliferation with it, they compare the different elements, they try to compare such patient with the other patient to see why the fibroblast or the Schwann cells are proliferating, why there are differences, to try to find a solution. Anyhow, we're on this stage for your disease. The final goal would be to have this. We hope we can have this. But what we think, progressively, if we can improve there and improve a little bit there, to progressively push the boundaries and not trying to find the solution, the drug which will be the Holy Grail, which I think we will not see at least in the next 50 years. What we will see is new treatment where there are surgical, medical, or combination of both that will progressively improve not only the life but also the quality of life of the patient. Thank you.